Yeah, okay. We are also on YouTube now. So Shilpa madam, you can start.
Yeah. So this is our ninth session of this Fertility Masterclass. And I'm very, very pleased to announce that the views have crossed more than 30,000 on YouTube. And I immensely thank everyone for making use of these very, very practical masterclasses. At this outset, I would like to thank Dr. Jay, who has really selflessly taught all of us about these protocols and the clinical aspects of infertility, which is very difficult to find even in the textbooks or even after doing fellowships. And I have tried, I have read, I have theory, I have seen many a times that it's not a very practical thing. And so I'm very happy that we are having these sessions, and I'm very grateful to Dr. Jay for doing this. Though he is very busy and he's occupied in the OT, he takes out time every single day for 20 minutes to 30 minutes to do this for all of us. And I hope that this series continue like this, and all the gynecs are benefited by this. So thank you so much.
Yeah. Random start protocol is actually like this. It is 4 o'clock and 10 minutes. So let's assume somebody walks inside your OPD at 4 o'clock. Okay. Has no preparation for doing anything in life, comes inside to your OPD and tells you that, look, I really like you. I saw all your masterclass videos and I am in India for approximately 20 days. But I promise I will come back to India for doing a frozen embryo transfer with you. Okay. But right now you do my stimulation, take out my oocytes, how many ever you can. Okay. And make my embryos out of this. This is the exact definition of doing a random start protocol. Okay. There is no time of the day. There is no day of the menstrual cycle, okay, which you are planning for, and you can start the patient on a random stimulation. Okay. This is something which is important, which you have to keep in mind. So I will share the whiteboard and I will share you the indications for which we predominantly would want to do this. Okay. So of course, Shilpa madam, I hope it is visible, right?
Yeah, it is.
Okay. So we are going to do a random start protocol. Okay. The most common indication is this oncofertility. Okay. Because you don't really know on which day of the menstrual cycle you are going to be diagnosed with a breast tumor, lymphoma, leukemia, rhabdomyosarcoma, all these things you don't really know. Okay. Second, common indication, if you are an international patient, clinic is for international patients. Okay. Third indication is going to be for social egg freezing. Okay. These three are the most common indications where you would be doing anything like this. In our clinic, the most common indication is oncofertility. We would be doing approximately 7 to 8 such cycles every month. And second is international patients who are unable to match timings and come to India at any given point in time. All these three situations, the most important mandate in a random start protocol is freeze on. Okay, you have to freeze everything what you get, because there is going to be a gross endometrial to embryo asynchrony, okay, in this particular effort of doing a random start protocol. Okay, so basically this random start protocol is somehow like me. Okay, it is challenging all the traditional concepts. Okay, sometimes right, sometimes wrong. Okay, but it is challenging everything which is a traditional concept. So what is our traditional concept? It is very simple. When we look at a particular ovary, we think that whenever the patient is on day 2, day 3 of the cycle, there is going to be a bunch of antral follicles. Once this day 2, day 3 becomes approximately day 8 and 9, one of them is going to become a dominant follicle, others are going to be atrophied. When this goes till approximately day 14, it becomes a dominant follicle and those poor guys have gone severe atrophy. Following which, there is going to be ovulation, and after ovulation, it is going to form a corpus luteum, and these guys cease to exist. Okay. So whenever it forms a corpus luteum, this is going to be, let's assume, on day 18 to 22. And if there is no pregnancy, you are back to where you were. This is your traditional concept. Okay. Now, what are we trying to take benefit of when we are doing a random start protocol? Actually, the wave theory states that at every day of the menstrual cycle, there are some follicles which are present, which are getting recruited. Okay. It may or may not get recruited as waves, but there are some amount of recruitment which is happening daily. So if I draw, it is like a running race. Okay. See, this particular follicle, okay, let's assume this particular dominant follicle is in the race here. Okay. The other guys are still here. Okay. The referee is yet to say chew. Referee is yet to say go to these particular follicles. Okay. And these particular follicles, every day, what will happen is some will apoptose. The ones who apoptose, new people will come. Okay. Again, next day, some will apoptose, some new people will come. Okay. So you are trying to take advantage of this concept. Your advantage of the concept is that there is daily or wave recruitment of follicles. Okay. So what typically happens is, let's assume this lady has come to you on day 8 or 9. You are of the opinion that now, because the follicle is already 12 millimeter in size, rest of the follicles have undergone apoptosis. Okay. So if I do an ultrasound, despite me seeing these small follicles, I think they are apoptotic follicles. But the theory says that they are recruited follicles. Okay. But you have another problem. You will always say that on this day the estradiol level is more than 100, FSH level is approximately 6 to 12, LH level has become more than 5. How do I end up stimulating in this particular phase? What do I do to stimulate? Okay, the answer which we have described before and we will describe again is very simple. Any follicle you take on earth at any stage, if you cause a GnRH antagonist pre-treatment. If you give GnRH antagonist for 2 to 3 days, what is going to happen is that the down regulation and suppression is so much that the FSH value will drop down, LH value will drop down, and this particular guy will undergo apoptosis. Please remember, these boys 1, 2, 3, 4, 5, these guys are FSH independent. Okay, these small follicles don't really need FSH. So even if you block the FSH at this level, the new recruitment will keep on happening. But this particular guy, which is a dominant follicle, 12 mm, 15 mm, 18 mm, 19 mm, everybody is dependent on FSH and estradiol in some way or the other. And if you cut off their blood supply, these guys are going to die. Okay, so you really want them to die first, and once they die, you have this fresh batch of newly formed recruits whom you are going to recruit. Okay, once you recruit these guys, your stimulation is simple. You give GnRH agonist pre-treatment, and you then load them up with 375 international units of HMG, and you continue the protocol just like any other antagonist protocol. So basically, once out of this 375 international units of HMG, after administering it for 6 to 7 days, you are going to have some follicles which will reach 12, 9, 12, 13 millimeter in size. You add your antag shots, 4 days of antagonist, and then you trigger with a GnRH agonist. Okay. Here you can also use a dual trigger. Okay. If the patient is flying out of country, but in oncofertility patients, in this situation, we always use a GnRH agonist trigger. There is another addition which we do for patients of oncofertility, that is, we give letrozole 2.5 mg daily till we finish off the stimulations. Just stop the letrozole 1 day prior to starting your chemotherapy, which is more than enough. Okay, so basically this is your random start protocol. This is how you are supposed to do it, by taking advantage of this. So actually, whenever I try to give an explanation of this random start protocol, I have always given an example that, this random start protocol is like the terrorist camp. One person undergoes suicide bombing, a next batch of recruits is ready. These people have a next batch of recruits ready to undergo one more suicide bombing. So it is the same thing. You have done suicide bombing for this particular guy, a next batch of recruit is ready. Okay, and you are stimulating them, you are training them so that they give you oocytes. Okay, one important point which people should understand about this entire technique which you are trying to follow. Okay, please remember that in this type of situation, if let's assume your antral follicle count, or let's say your AMH is 5, okay, so you are expecting 20 oocytes. Whenever ever you are doing a random start, okay, whenever you do a random start, please remember your total number of embryos which are going to be formed are going to be slightly less. Okay, slightly less. Okay, your oocytes will be slightly less by 2 or 3 in number. Okay, oocytes are slightly less by 2 in number, embryos are slightly less by 2 in number. Okay, the reason why I'm explaining this to you is because this is an important point of counseling. Okay, to the patient, you must tell your patient that, look, in an otherwise normal situation, if I would have got, let's say, 10 oocytes out of you, when I do a random start, I am going to get 8. Okay, just you can explain this to the patient. It is very good to do this. It is very good to understand that in very rare situations, especially when you are doing a random start in patients with very low AMH, okay, especially AMH of less than 1, okay, this recruitment is also not very good, as a result of which you may have just 2 follicles which are getting recruited on a particular day. And in very low AMH patients, random start protocol may or may not be extremely beneficial to you. The best person to use random start protocol is your normo responder. The second best person is your hyper responder. In a patient with low AMH, random start protocol has to be used guardedly. You have to tell the patient that because of this recruitment, because these follicular things are less, you may have a cycle cancellation even if you are doing a random start, despite your availability in the country. Okay, so this is something which is very, very important, very practical, and I learned it only after I did a few cases of low AMH patients, that it should not be told, and you will have this less number of recruitment when you are doing something like this. Okay, apart from
Can you
this,
put up your picture on the screen, please?
okay,
Yeah.
Thanks. Okay, so apart from this, what is very, very important for people to understand, a lot of times people have this challenge in mind that when there is a corpus luteum which is already formed in the luteal phase, the corpus luteum is already secreting hormones. Corpus luteum is already secreting chemokines, cytokines, relaxins. Okay, it is secreting a lot of other hormones apart from estrogen and progesterone, which we know. Okay, does secretion of these hormones cause a problem in recruitment and development of the new follicles? Okay, it doesn't. The answer is it doesn't. So don't worry about it. Even if you see a beautiful corpus luteum, okay, and the patient is on the 17th day of the cycle, okay, she has come to you for a random start, you can load her up with pre-treatment antagonist and you can start the stimulation. This will work very nicely in normal responders and hyper responders both. So keep that point in your mind. Okay, finally, whenever you are doing a random start protocol, there is no role of doing a fresh transfer. Do not even look at the endometrium. Kindly ignore the endometrium completely in a random start protocol. Kindly do not think of, even in your dreams, of doing a fresh transfer. This is a freeze all only. Okay, this is a freeze all cycle only. I normally add letrozole, as I mentioned, in all patients of oncofertility. It keeps estradiol levels very low. Okay, during the entire stimulation, you may choose to add it, you may not choose to add it, but in oncofertility patients, please add letrozole. There is no harm. Whenever you are doing a random start protocol, on the day of starting stimulation, you can do serum estradiol levels and serum progesterone levels. Okay, once you give your 2 or 3 days of GnRH antagonist, what is going to happen is that there is going to be a drop in that estrogen and progesterone because of the severe suppression effect. Okay, because of this, there is going to be a drop, and suddenly you will find estradiol has become 22, right from 185. Suddenly you will find that progesterone, if on day 19 is 24, this progesterone, despite the corpus luteum being present, this progesterone has gone from 24 to 2. Okay, even if the progesterone is 24, you can add HMG. It is going to act like your PPOS. You don't really then have to worry about any LH surge. LH is already surged. What will it surge more? Understanding? So you don't really have to worry about that, and you can start off your stimulation. Okay. I normally, in my practice, for practical purposes, I have reserved it only for international patients, only for oncofertility patients, and only for these very high-end social egg freezing girls. There are people who are working in film industry, people who are working in the airline industry, people who are working in a lot of industries where their travel and schedule is such that they get the schedule free only for 12 to 14 days. Usme you can't really go and tell them come back at the time of periods. When she comes, when her periods are coming, she will be shooting somewhere. She will be doing a show somewhere. So she can't really come and start the treatment in that manner. Okay, so you can do it in them. Output and results are equally good and equally effective. Okay, so I hope it helps as far as RST is concerned. If there are any more questions on this, I would answer. One more clarification. There is nothing that you have to use recombinant FSH only. Okay, you can really use HMG and it will give you equally good results. So don't worry about it.
Okay. So have you tried it in previous failure cases? I saw a study which said that in previous routine cases of follicular phase stimulation.
So the best thing to do a random start is when you see a corpus luteum. Okay, so we are going to have a session about this where we are trying to describe true luteal phase stimulation. When you have a corpus luteum, it is the luteal phase stimulation. It is believed that when you have luteal phase stimulation done, you may have little less oocytes, but the embryos which are formed are going to be more euploid, okay, as compared to the follicular phase embryos. I have not done PGTA testing to these. I have not done PGTA testing of these embryos, but definitely it happens very frequently with international patients, especially when somebody fails a particular cycle. No, the day they fail the cycle, they are in their menses. Okay, which is why they have consulted you. Okay, once they consult you, okay, they want to come to India like immediately. So they usually end up coming to India at their mid cycle. Okay, I will also tell you one very important thing. See, I am a little bad category guy. Okay. I have worked in biological labs for 21 days. Okay. Where IVF is done on pig, IVF is done on sheep, and IVF is done on cow. It is done in Bombay. Okay. So I'll tell you my experience in that. You can't really start stimulation in cow when she is in menses. Nor can you do this with the sheep. Nor can you do this with the goat. Okay. So in all of them, in animals, stimulation which is done is a random start stimulation. Okay. If people don't want to believe me, pick up your phone, call up your contacts, and all your veterinary doctors will tell you, okay, yes, we don't wait. We don't even know what is follicular phase. We don't even know what is luteal phase. How on this earth will you do a transvaginal ultrasound on the cow? You can't do it. Understanding? The ultrasound which is done in cow and pig is always abdominal ultrasound. Okay. So all stimulations are random start stimulations in them. I'll give you one more example, which I frequently do, and you must incorporate. All stimulations in patients with MRKH, with vaginoplasty. So I think I must have the highest series of MRKH stimulations. I prepare embryos, and when surrogacy was on, I used to form these embryos and cryoship it to 2 clinics in Bombay. Okay, and they give excellent outcomes with random stimulation. Okay, random start stimulation, because you don't know when she is going to be in menses, even if the ovary is functional. Okay, and even that gives a fantastic outcome when you do random start stimulation. Okay, so these are just practical things out of experience, which I just thought I must share.
Yeah, that was good. I mean, the MRKH, I think that is a very important point where the random start protocol may be of use, where we don't know when the menstruation is going to happen. So do you do this PPOS along with the random start protocol? Do you add
no
DM? You don't do that?
No, okay. No.
Okay, and how is your cancellation rates among 100 cycles? So
5%.
5%.
5%.
Okay, and is it like the same with your routine cycles of follicular phase monitoring?
No, routine cycles will be lesser, maybe 1 to 2%. But this 5% is also predominantly due to low AMH cycles. If you
Okay.
have a normal responder, you will not have cancellations.
Okay. So do you see there is longer duration of stimulation and more dosage of gonadotropins
2
in
days
random?
more.
2 days, just
Always.
like,
Yeah, just like how you have double stimulation.
Double.
Whenever you start anything randomly, it will take 2 days more. I think the reason for that is you don't really know that batch of recruits, no, when they will start developing that FSH receptors. We don't really know that. As a result of which 1 or 2 days of stimulation might go waste in the early days. Okay.
Okay, and I think in the midway they will get their menstruation because you are starting random. So even if the pickup comes during the menstruation, so is
no
there
problem.
No problem. Like
No problem.
Okay.
No need to arrest menses. No need to give tranexamic acid. See, your time to do egg pickup is what, 2 minutes or maybe 3 minutes. Okay. Just clean the vagina with normal saline. Put your probe. By the time the next clot comes out, your aspiration will finish.
Okay. And if your the OHSS chance in hyperresponders are there, so is there anything in particular, especially in CA breast hormone dependent cases, that you take care?
Always give GnRH agonist trigger and always continue letrozole 1 day before the chemo is going to start. Even for ER positive cancers. Okay.
Okay. Okay. So see, there are 3 categories. One is pre-ovulatory, ovulatory, and post-ovulatory. In these 3, the RSP works in which of these things? Like, I know in presence of corpus luteum, it may be good to do it. But if it is the peak of ovulation, say like on day 12, day 13, have you noticed any change in the stimulation?
So I do one thing whenever it is at the stimulation, I just give one GnRH agonist trigger there.
Yeah.
Instead of giving antagonist, I just give a GnRH agonist trigger. It will any which ways rupture and cause luteolysis. Okay.
Yeah.
And start letrozole. The day you give trigger, that is next day. Like Monday you give trigger. Okay. Wednesday you start letrozole. There will be luteolysis. 2 days after that, you can start your stimulation. 2 days after that, if it is ovulatory.
So Monday you give agonist. Wednesday you start letrozole. Friday you start
Friday you start stimulation. No problem.
Yeah. I think this was good. Yeah. So in cases of thrombocytopenic patients who have malignancies and they come to you, so is there any precautions that you take when you are doing this random start protocol?
You add letrozole. See, you have to prevent estrogen from peaking out. Okay, basically. Okay. So you add letrozole. It will prevent estrogen to peak out. Second, if you are worried in that situation, add low molecular weight heparin 40 units. Okay, that will also help whatever little it wants to help, but it is not mandatory to do that. Okay.
Okay. Yeah, I think that's about it. So this is mainly for IVF only and freezing only. So people are asking questions for IUI. So this is not.
No, this is not for IUIs. Sure.
And any gap to be given after giving Antag for 2 to 3 days before you start gonadotropins?
No.
So Indrani madam has asked. So do you give
Indrani madam from Kolkata? Hi.
So what about giving metformin for 3 months before the stimulation? I mean, that we can do it, right? So
it's up to you.
Yeah. So Indrani madam is saying hi.
So I think somebody, Meghashri madam, has raised her hand. We'll allow her to speak. I want her to start her video simultaneously. I want her to unmute. Yes, Meghashri ji, boliye.
Hi, all talks are excellent. Yesterday I could not attend. I would like to ask one of my patients. She had one dominant follicle only. She was a routine AMH patient, but in midway she said, no, I want to go for IVF, as her husband was on antipsychotic drugs. and we had severe oligosteroid. So she said, no, you start now only IVF for me. It was 9 days. I gave her antagonist 2 doses today, 2 doses tomorrow. After 3 days, we thought starting stimulation. Was it right on my part? That I wanted to know. How are the results if the patient
You will
says
get
that they want to
2
go for
less.
IVF?
You will get 2 oocytes less than what you were supposed to get. Apart from that, the results are good, madam. No problem.
And one more query, not regarding this, modified natural cycle. As you said,
that we will discuss. No, that we will discuss in MNC or on WhatsApp. This session only for random start. Okay.
Yeah. So I think it was an excellent talk, Dr. Jay. I mean, we started with agonist, which was a longer duration of stimulation. Then we came to antagonist cycle, which reduced the stimulation number of days. And now I think we are into random start protocols, which again further reduces the stimulation number of days. And it gives a lot of, I think, flexibility to the patients and also to the consultants. No, though not many people, as far as I know, practice random start protocol, because oncofertility, I think very few people in India are doing it. And I know that you have immense experience in this. So it was excellent. Thank you very much. I thank everybody who joined us live for this session.